What I'd like to do is just very briefly share with the community some really exciting new developments that happened around ASCO and that I was lucky enough to have the chance to highlight to a relatively large audience of people, really demonstrating for the first time in many, many years, we've got new treatment options in adenoid cystic cancer. So I guess I don't need to tell this audience that adenoid cystic is a MIB-driven disease. We've learned in recent years, largely driven by the work from Renata Ferrarotto, that we can classify this disease that we used to think was universally a relatively indolent disease into two different types. There's the type 1 disease, which is the bad version of this disease. It's driven by MIB, but it also has activation and often amplification of a gene called MYC. And it often has mutations in a gene called Notch that activate Notch. And we see that disease as an aggressive disease that tends to recur early after the initial diagnosis and often spreads to sites other than the lung, including liver and bone, but it can go anywhere actually. And then there's the type 2 of the disease, in which again MIB is activated, but now we see maintenance of this protein called P63, which is lost in type 1, maintained in type 2, and this is associated with a much more indolent, slower growing disease that recurs later, and the metastases tend to stay in the lung for a very long period of time. So that's the type of disease that we've seen. We've learned recently that we should be classifying this disease. So instead of just saying someone's got adenoid cystic carcinoma, I think now everybody should expect that they know is their disease a type 1 or a type 2 tumor, because it will tell them to some extent how rapidly this disease may progress. And it may be cured, of course, but if it is going to come back, it gives you some indication of the prognosis. And you can see that the markers are there. So MYC positivity in type 1 and TP63 positivity in type 2 disease. Now, we know that the disease is driven by this fusion event. And again, I'm not going to go through this in great detail, but basically what happens is that during cell division, or during normal cell maintenance, a chromosomal break occurs in more than one chromosome, and the cell, in trying to fix those breaks in the chromosome, accidentally stitches them back in the wrong place. So in the classical version, a piece of chromosome 6 ends up on chromosome 9, and a piece of chromosome 9 ends up on chromosome 6. And this is what causes all of the problem for most patients. And it is a process that we can potentially target now with drugs. So the data that I was able to review at ASCO looked at this drug, which is the remix drug, the REM422 drug. Now, when you get that stitching together of the chromosomes, what we get is that we get a messenger RNA. This is the thing that comes from the DNA to tell the cell what protein to make, and in the case of a gene rearrangement, it's going to make a protein that shouldn't exist in nature, but which is capable of driving the disease. Now, in a proportion of patients, about half the patients, a little under half of the patients, they will have this particular marker within that messenger RNA called the poison exon, and that is a target for a drug that allows the cell subsequently to degrade, to destroy that messenger RNA so the protein isn't made. Now, if the cancer relies on the protein and we can get rid of the protein, maybe we can begin to see responses of the disease. And on the right-hand side of the slide, you can see evidence that the MIB messenger RNA is being reduced by significant amounts across a range of drug doses between 6 milligrams and 48 milligrams in this trial. And at the bottom of the slide, the little brown areas that you can see, those are the staining cells that are positive for this protein called MIB. And on the right-hand side of that bottom panel, you can see that that brown staining is significantly reduced. The drug is doing its job. This is the most important slide from this presentation from Renata Ferrarotto earlier this year. Real responses. So this thing is called a waterfall plot. Anything that goes south of the 0 line indicates that tumors are getting smaller. And at the bottom of the slide, you can see a PET scan in which these areas where the sugar is being taken up into tumor deposits, these have gone away on treatment. And these reductions in the size of tumor are really unprecedented. Sadly, I've been looking after people who've had adenoid cystic carcinoma for more than 30 years. And I have never seen anybody have a demonstrable response like this. This is really a watershed moment in the management of this disease. You can see here, looking at the various individual doses, that there are responses at all of the levels, but anything around 24 and above milligrams is giving us responses. And on the right-hand side of the slide, you can see that at 24 milligrams, 43% of people are responding, and anything at 24 and above milligrams, 1 in 3 people are responding. So this is the sweet spot for dosing of this drug. Now, at the same meeting, Alan Ho presented data on a poster from the Argenta study with the RGT61159 agent. This is another tablet medication that can prevent the splicing, the removal of that piece of RNA that's normally cut out of the transcript, as it's called. And by stabilizing that, it promotes degradation of the messenger RNA and stops the protein being made. So the disease is driven by the protein. We stop the protein being made. We attack the disease. And we saw that at a dose level between 60 and 84 milligrams, we saw a significant reduction in the level of MIB protein within these tumors. And you could see again in this waterfall plot a number of impressive responses to this drug. Now, the data are a little less mature, but nonetheless, this is an impressive data set and something that we're going to take forward into phase 3 clinical trial. And I'm really excited to say that this is a study that will come to the United Kingdom and that we will have the opportunity, we hope, to offer patients the chance of receiving drugs like this. And Emma, I know that you're involved in planning that study and helping with that study. And for that, we're very, very grateful. So the third and final thing I want to talk about is another really exciting area. Now, this is using a drug called an antibody drug conjugate. Now, this, and I'm going to just talk you through this Y-shaped thing over here on the left-hand side of the slide is an antibody. Now, this antibody will bind to a target on the surface of cells. Now, the target here is something called B7H4. What that does doesn't really matter. Just the fact that it's expressed in patients who have adenoid cystic carcinomas, it's on the surface of their tumor cells, is important because this antibody can then bind to those tumor cells and it carries on it a payload. And this payload is effectively a potent cytotoxic chemotherapy drug, the sort of drug that you can't give by intravenous administration on its own because it's too toxic. But if you put it on a sort of FedEx type system and deliver it to the tumor by actually taking it to the correct address and then releasing it, you can give these drugs that otherwise you wouldn't be able to give. And in this study that was presented by Glenn Hanna, he looked at a population of patients with type 1 ACC, the bad players of disease. So again, the solid morphology, early relapse, patients with Notch mutation, c-MYC overexpression, and p63 negativity, all the bad markers of the disease. And look at this waterfall plot with this drug, which is called emiltatug ledadotin, a bit of a mouthful. Thankfully, it's known as Emily. And you can see again, this is the 0 line, and you can see the numbers of patients who are responding. Response rate here of 36%. Dramatic responses in some patients, including complete remission. And we've got some hints that maybe some of the biomarkers, Notch mutation, solid morphology, telling us who may benefit. These are exactly the sort of people who need these sorts of therapies. So this is hugely exciting. And I think, from my perspective, Emma, this is really, I hope, the dawn of a new treatment opportunity for people with adenoid cystic cancer. Yeah, but well, not accurate timelines, but the hope and the expectation that we will be going through the administrative aspects of this within the course of the rest of this year, and I would hope that early next year we may have some good news around that. I think it's important to emphasize that this is going to be very carefully selected, and there's a biomarker. This poison exon is a biomarker. It needs to be present. And there will also be other criteria around the size of the disease, the rate at which it's changing. So it's not going to be just for everybody, sadly, not in the first instance. But there will be, I hope, within the course of the next 6 to 9 months, there will be an opportunity for those who qualify and those who need it potentially to take part in a study. And in advance, I thank them because, of course, patients are so generous with their time, their bodies in providing us with the ability to test these new treatments and hopefully bring things forward that can help the wider community. So I hope there'll be good news coming forward very soon. So around all of this analysis, there was the initial assessment of what was safe and what was not safe to give these drugs. So the drugs that are given tagged to the antibodies, I called it a FedEx system, or maybe that's a proprietary thing, I don't know. But anyway, the idea is that by putting the antibody on a protein that carries it to a place, it's not available in the circulation to the same way as if you just give the drug intravenously. But you still have to do the proper safety evaluations to make sure these things can be given to people safely. And those indeed have been done. These drugs don't come without side effects, and we have to be very careful how we use these drugs. But I think for me, the really compelling thing, over and above the fact we know that you can do it safely, is that I've spent many, many years telling people in the clinic that they shouldn't receive chemotherapy because chemo just doesn't work against this disease. That is true. And that's because the drugs that we have been trying up until now have been lacking in potency, and we're not able to give them in big enough doses for them to make any effect. But now we're able to give drugs that otherwise just aren't safe, but they now have become safe because we deliver them right into the locality of the tumor. And we see for yourself, you can see the response rates there. So yeah, we can't be blasé about this, Emma, as you know, but I think for me, this completely changes my attitude to chemotherapy in this disease. And again, I'd now be willing to consider offering this treatment to patients. I'd like to imagine that was true. And I think to some extent, sporadically, it can be true. And so I think that there is a willingness to try to help people who have unusual diseases, diseases where you can't just get a quick 700 patient randomized phase 3 trial like you can do for some diseases like breast cancer, lung cancer, prostate cancer. So I think there is a willingness now to support this. But there is also, I think, an understanding that these things cost a lot of money and they're not trivial to do. And that's within the regulatory framework. But there's also the conversation that we need to have with pharma partners. Because, of course, pharma partners, there's a tendency to go after the blockbusters where the markets are large. And not necessarily to develop things where the markets may be small, but the need is high. But I think there is an increasing alignment around the fact that we do need to find new treatments for people with, these so-called orphan indications, these unusual disease types. But there's a lot more to do, and communication is key, Emma. And I think, an organization like Salivary Gland Cancer UK is absolutely integral to getting that message out there. On behalf of the oncology community, I thank you for what you do and all of your members. And I hope that we can continue to deliver on our promise of trying to make things better.